Morning, everyone. I think it's still morning. I see Ambassador Chiambore in front of me, and she gave us the call to action, and I'm going to try to respond a little bit. I don't think I'll be able to talk as fast as Ambassador Jenkins, but I'm going to try to stay within my time, hopefully. To deliver to treat disease and to promote health, one needs a proper healthcare system. It has to be strong. And you can't approach the disease simply from the basis of the disease. You have to treat it within a system that is strong enough and integrated enough to deal not only with symptoms, but with causes. So I've entitled my little talk here, Towards a Workable Healthcare System for Africa. Africa has 11% of the world's population, but carries 25% of the global disease burden, 49% of maternal deaths, 50% of under 5 mortality, 67% of the HIV burden, and 85% of the malaria burden. It has 1.3% of the global health workforce and spends only 3% of the world's total expenditure on health. I got this from Dr. Francis Amazwa, who is from Uganda. The major communicable diseases are HIV, AIDS, malaria, tuberculosis, respiratory infections, diarrhea, and a group of 14 diseases grouped as neglected tropical diseases. Non-communicable diseases, mostly diseases of the heart, vascular system, diabetes, and cancer, cause a high burden of disability, along with maternal, perinatal, and nutritional causes. Clearly, health resources have to be mobilized as rapidly and inexpensively as possible, and health systems strengthened and improved to address the problem. To be effective, adequate numbers and quality of health workers need to be assured. To be efficient, the outreach, diagnosis, and treatment modalities need to be integrated and delivered at the rural community level, where 75% of the population lives. The World Health Report in 2006 estimated that sub-Saharan Africa needed 1.5 million more health workers to meet minimum needs and address Millennium Development Goals 4 and 5. Using the Western model of scientific medicine, based on doctors, nurses, hospitals, and highly complex technical procedures, Africa will never bridge the gap due to the expense of training and the associated brain drain. Actually, if every doctor and nurse who was first trained in Africa and migrated was to return, they would solve less than 10% of the problem. Many more people need to be trained locally to occupy various positions in the health system. A paradigm shift is needed towards prevention, proper nutrition, health education, public health measures, primary care, and early treatment, as noted in the Alma Ata Declaration. By the way, that was way back in 1978. The Global Health Workforce Alliance suggested scaling up education and training curricula with a focus on community health workers. The World Health Organization recommending training to task to create a cadre of health workers trained in specific skilled tasks that do not require a medical doctor or a registered nurse. Example, midwives and clinical officers to do cesarean sections, gynecologic and trachoma surgery. If scaling up and task shifting are implemented, along with ICT for distance learning, a rapid expansion of the number of community health workers could be produced, as well as increasing retention in the rural areas and a reversal of the brain drain. Women and children are disproportionately burdened. Childhood growth, intellectual development, and resistance to other infections are impaired. 4.8 million children die annually from pneumonia, diarrhea, malaria, and measles. Easily prevented with a few basic interventions, such as clean water, proper sanitation and hygiene, adequate nutrition, oral rehydration, immunizations, and insecticide-treated bed nets. Roughly 1 in 20 women will die of a condition related to pregnancy and childbirth. Again, a small set of interventions will deal with much of the problem. Access to primary care, antenatal care, deliveries by skilled birth attendants, postpartum care, and access to emergency obstetric care for difficult and complicated deliveries. Prevention chemotherapy of neglected tropical diseases with mass drug administration can be integrated with maternal and child health packages and delivered at the community level by community health workers. This integrated disease management would also address HIV, AIDS, and cancer that requires long-term management of symptoms and extensive surveillance. We propose the use of innovative technology to train community health workers in partnership with the Ministry of Health. Training would be at the Health Sciences Center in the community, and delivery of care would be via community health centers. The trainees will be high school graduates and traditional healers. The learning materials and teaching modules have been developed by the Ethiopia Public Health Training Initiative, working with the Carter Center and Emory University, and have been used with excellent results in Ethiopia since 1997. These training modules can be converted for delivery using ICT. The most up-to-date technologies can be used to facilitate online learning, including video and audio conferencing, sharing documents, synchronous and asynchronous communications, utilizing internet-connected computers, smartphones, and tablets. Trainers can be local MDs and nurses and technical experts, and supplemented as needed by diaspora personnel as volunteers. Because of the connectivity, the training program will use a blended approach which will allow students to stay in their own communities for most of the program, and trainers can be at a distance, including overseas. The 4-year program would focus in the first year on material related to neglected tropical diseases, maternal and child health, and sexually transmitted diseases, including HIV/AIDS. This would facilitate community education relative to the prevention of diseases. Year 2 would have an enriched curriculum that will graduate community health workers competent to be in charge of community health centers, to be technicians, example EKG, ultrasound, X-ray, and laboratory technicians, and be able to handle biomedical equipment. Year 3 would graduate nurses, midwives, and integrated traditional healers. And the 4th year would graduate clinical officers in surgery, medicine, and pediatrics, who would be competent to be in charge of clinics and be the backbone of services at the community hospitals. With connectivity, this will be integrated into the existing healthcare system, as well as incorporate overseas medical and other personnel who can contribute on an ongoing basis. Thus, both at the community and the tertiary level, the number of quality of healthcare personnel can be increased significantly in the shortest possible time. It is of great importance to bring the traditional healers into the health system, as they are the bearers of endogenous knowledge accumulated over thousands of years. I would like to remind you that the first documented use of herbal medicine in Africa from around 3000 BC, and it's recorded in the Ebers Papyrus. Of course, this occurred in Egypt, which is our classical civilization. Now, the knowledge of the traditional healers of herbal medicine is unparalleled in the community, and their use of non-physical methods of healing are now being validated in the West as energy medicine and the use of, quote, subtle energy. Supposedly newly discovered, but previously denigrated as shamanism, voodoo, witch doctor, black magic, and as part of the superstitions of primitive people. Actually, it is as primitive as quantum physics. And this has shown that conscious directed energy is the determinant of material transformations. I would like to share 2 quick examples of an integrated approach to healthcare and systems development. Doctors Lowe, Lockhart, and West, after 10 years of research at the University of the West Indies, developed Canosol, a sterile ophthalmic preparation for the management of glaucoma from the cannabis sativa plant in 1978, one of the earliest medicinal uses of marijuana. Since then, Dr. Lowe, as head of Biotech R&D Institute, has been engaged in the research, development, and commercialization of health and wellness products. from Jamaican plant-based materials. Through the Institute, he has developed several bioactive molecules from Jamaican medicinal plants, most recently the Jamaican ball moss, useful in cancer therapy, diabetes, HIV/AIDS, hepatitis C, and neurodegenerative disorders. Various other products are marketed, such as alpha prostate formula, an anti-cancer dietary supplement to aid prostate health, a diabetes formula, joint flex, an anti-stress formula, women's complete, men's complete, etc., and several medicinal herbal teas, utilizing guinea hen, ball moss, kola nut, cerci, soursop, moringa, ginger, and cinnamon. All meet FDA requirements and are developed in a good manufacturing practice certified facility. There are over 500,000 plant species on Earth, most in tropical and subtropical areas, and only about 15% have been screened for medicinal use. In 1978, Germany established the Commission E, that is Commission of Experts, and to date they have put out more than 300 monographs based on herbal remedies. Over 90% of German physicians prescribe herbal medicines. This is legal, and they teach it in their medical school. Of the 155 anti-cancer drugs developed since the 1940s, 73% were either plant products or a derivative thereof. One example is the periwinkle, which is indigenous to Jamaica, Madagascar, and other tropical places. Two substances, vincristine and vinblastin, are extracts used to treat leukemia and Hodgkin's disease. Of course, the poster child is Taxol from the Pacific Q, which is the most prescribed anti-cancer medicine presently for ovarian, breast, and lung cancer, leukemia, and lymphomas. There's a 60 billion world market for herbal products, which is expected to grow to 5 trillion by 2020. This is something that your traditional healers can bring in to your medical practice and the country can profit from. My second illustration is laboratory testing plays an integral role in modern healthcare. The College of American Pathologists estimates that between 60 to 70% of all diagnoses depend on pathology, including early detection and diagnosis of cancer. The success of cancer treatment is related to the stage of the tumor at the time of diagnosis. Shortage of pathologists in developing countries is a significant obstacle to early diagnosis, treatment, and high cure rates. We're familiar with an open mobile telepathology system that produces whole slide imaging from glass slides that are accessible for remote analysis using viewing software. The system utilizes a standard light microscope with a custom-built 3D adapter and the iPhone 5S. Composite images are acquired and transported through the cloud using the Pocket Electronic Health Record database and then accessed through web and mobile platforms. It can be used in any part of the world with an internet connection. Cervical cancer ranks as the leading cause of mortality among women of reproductive age, due to the fact that 80% of these women have not been adequately screened. Haiti has the highest incidence of mortality from cervical cancer in the world, 94 per 100,000. There are 5 pathologists in Haiti, a country of 10 million people. A program of screening and utilization of the mobile telepathology system has been initiated there, with many of the slides being read at my home hospital in Long Island, North Shore Long Island Jewish Hospital, the Department of Pathology. There's a 95% concordance with static slide viewing. The program is called Test Early, Live Longer, and it was started in 2013 and consists of 5 steps. 1, screening the at-risk population. 2, processing the cyto or histopathological slides. 3, transporting the images to the pathologist. 4, timely interpretation and reporting of results, and 5, follow-up and delivery of proper care to the patient. The total cost of the system is $2,000 compared to others that range from $30,000 to $300,000. At the front end, it requires only a high school graduate with 1 to 2 years of training. I myself, after leaving high school, went to work in the laboratory in Kingston, Jamaica, and I can attest to the fact that after 1 year of rotating through the different departments, I could prepare slides properly and actually even read them. At the back end, it needs more pathologists, whether they're volunteer pathologists or paid. So with early diagnosis, expensive, highly technical and complex surgical treatments, radiotherapy and chemotherapy can be minimized or avoided. In conclusion, I'd like to say that utilizing our rich human and plant-based resources with appropriate technological advances, we can rapidly develop our healthcare systems, integrating various approaches with emphasis on holistic treatment focused on the community. I'd like to quote Dr. Miriam Kamadi Weir from Kenya: "If it doesn't happen in the community, it won't happen in the nation." Thank you.